Hello and welcome to this fourth year lecture. This lecture will be divided into two sections. The first part will be on vomiting and reflux, and the second part will be on acute infectious diarrhea. Please make sure that you use this lecture in conjunction with your lecture notes as well as the relevant chapters in Cuvadia. We will start with vomiting. It is important to know the difference between vomiting and reflux and to be able to ask the parent the necessary questions so that you are able to distinguish between the two. It's not always that simple, but you need to try as best as possible. So with vomiting, it's a forceful oral expulsion of your stomach contents. It's coordinated by a central nervous system. You get contraction of your abdominal muscles and your diaphragm, and you get relaxation of your lower esophageal sphincter. This is usually associated with some autonomic symptoms. However, in a very small child, it's very difficult to elicit this from the history. If we look at the physiology, there's various triggers that will cause vomiting. These can come from your gut, from your eyes, from your ears, from your nose, or higher cortical centers. If we look at this diagram, you can see that some of the vomiting will go via your chemoreceptor trigger zone, and the rest will stimulate the vomiting center directly. And as I've mentioned, it is a coordinated process. When we look at the causes of vomiting, you need to look at the patient's age, and you will see in Cuvadia in the chapter in vomiting, there's a very nice table there that differentiates the causes based on the patient's age. But together with that, you need to also think of a systemic approach. I generally find a systemic approach is much easier to remember the causes of vomiting, but you need to combine the two when looking at your patient. If we start with the gastrointestinal system, it's probably the most common area, and you get things such as anatomical problems, motility problems, appendicitis, NEC. Neurological causes, raised intracranial pressure, trauma, migraines, especially in your older children, and sometimes even convulsions. Infections, diarrhea being one of the common ones, we'll talk about that later, but even UTIs, ear infections can also present with vomiting. A little bit less common, but patients with first presentation of diabetes, especially if they present with DKA, can present with vomiting, and there are also renal causes. Respiratory causes such as pneumonia and sinusitis, and then we start thinking of the less common things, inborn areas of metabolism, immunological causes, and if you have a patient who's in childbearing age, don't forget about pregnancy. Vomiting is such a common symptom, so we need to know when are we going to be worried about it. What are the danger signs? So any bile stain or fecal vomiting is obstruction until proven otherwise. We need to exclude obstruction. Blood-stained vomit is a concern. Projectile vomiting, especially in a male around 6 weeks, you need to think of a pyloric stenosis. If the vomiting causes dehydration or any acid-base or electrolyte abnormalities, if there's any significant weight loss, if there are other signs of intestinal obstruction, we need to be careful. Neurological symptoms or other systemic infections are also important danger signs. Management of vomiting, treat the cause. Vomiting is a symptom of something else. You need to find the cause, and when you treat that cause, the vomiting will subside. Obviously, you need to look for complications of vomiting. If there are electrolyte abnormalities or dehydration, those need to be treated accordingly. And in very few cases, you might need to use medication. Please do not use Maxolon in children. It is contraindicated. In cases, for example, your patient's receiving chemotherapy, you might consider an antiemetic, something like a Dansitron. All right, so now let's talk about reflux. In contrast to vomiting, reflux is a passive process. It's involuntary, it's more physiological. You get retrograde flow of your stomach contents into the esophagus. It's not under neurological control, and there aren't other associated symptoms with it. Usually it starts before 6 weeks of age, and in most cases it will resolve by 1 year of age. It is very common in infants. Up to 60% of infants will have reflux. And the reason for this is because there is a short abdominal esophagus, we have delayed gastric emptying, and you have a transient functional immaturity of the esophagus and the stomach. Because it's such a common symptom, once again, we also need to know when are we going to be concerned. So if you have any complications of reflux, then we will actually refer to it as gastroesophageal reflux disease. Complications will include failure to thrive. These patients generally are often irritable and they don't sleep very well. If it is associated with respiratory symptoms, especially your infant that comes in with recurrent wheezing and you cannot find another cause, think about reflux. And if it complicates with esophagitis, then you need to also consider it as a reflux disease and manage accordingly. Very, very important, make sure that there are not other causes that is causing the reflux, because those are the patients that will need further investigation and management. A nice clue is that physiological reflux seldom starts before 1 week of age or after 6 months. If it starts within those periods, you need to think of another cause. When we take the history, it is very important to take a very detailed history. We need to know the age of onset of the symptoms, and we need to know a lot about the feeding. If it's a child who's on formula milk, we need to know what type of milk is the patient getting. How are they mixing the formula? How much is the child drinking with each feed? How often is the child feeding? If it's a child who is breastfeeding, once again, how often is the child breastfeeding? How long does the mom breastfeed for? You can perhaps look at features of the mother's diet and even the time interval between feeding. It's also important to know what the family has tried already in terms of medication or possibly dietary interventions so that you know where to continue with your counseling of the patient. The pattern of when the regurgitation occurs is quite important. Family history is important. Looking at the growth trend, look at the Road to Health book, see the patient's growth trend, plot the patient and see where they plot. Are there any environmental triggers, especially secondhand smoking? And are there any warning signs? So warning signs that make you think of other causes that could be causing the reflux. So a patient who is not growing well, who has fever, who has irritability, or it started outside of the age groups that we've previously mentioned. If there are other neurological signs, and if there are other gastrointestinal signs, you need to think of other causes, and these patients need to be investigated appropriately. So what else must you think of in a patient that has reflux? Make sure it's not an obstruction. Perhaps think of a cow's milk protein allergy, inflammatory bowel disease, other neurological causes such as hydrocephalus or intracranial lesions. Think of your metabolic causes, infections, and there could be other causes. It will not be the case in most of your patients. That's why it's so important to take a good history and to do a good clinical examination. So your diagnosis will be based on your history and your clinical exam. Your special investigations are done to rule out other causes, and these are done if there are red flag signs or if you suspect another diagnosis based on your history and clinical exam. It is important to note that there is no single gold standard investigation that you can do to diagnose reflux in infants and children. The special investigations that you can do, barium swallow, but that's to exclude other anatomical abnormalities. You can do pH monitoring with an esophageal probe, and if you think there's esophagitis or strictures, you can do endoscopy with biopsy. The rest of your investigations will depend on what you find on history or clinical examination. When we look at management, for all your patients, you can start off with your non-pharmacological or non-surgical things that you can try. So, what would you suggest to the family? To give smaller feeds, but give it more regularly. After a feed, they should elevate the head end of the crib for about 20 to 30 minutes. However, if the child is sleeping, we do not recommend that you do this. The milk feeds can be thickened. There are various ways to do that. If a patient is on formula, you get anti-reflux formulas that thicken when they come into contact with the stomach or the acidity of your stomach contents. Avoid exposure to tobacco smoke and reassure the parents or caregivers. It can be a very distressing thing for a parent to go through reflux with their children, especially in a first-time mum who's really struggling to adapt, who now also probably has a lot of hormonal changes, is also tired as well because the child is not really letting her sleep, which is all normal parts of parenthood. So they do need a lot of reassurance. If a patient has gastroesophageal reflux disease and the symptoms do not improve after 2 weeks of conservative management, then you can consider cow's milk protein allergy. In a breastfed baby, you can eliminate cow's milk from the mother's diet. In a formula-fed baby, you can change the formula to a hydrolyzed formula or an amino acid-based formula for about 2 to 4 weeks and see how the child responds. There are also pharmacological things that a person can try if there's reflux disease. There are no complications. We do not go this route. You can try antacids. It neutralizes the gastric acid, but we don't use these long term. Your prokinetics such as Maxolon and erythromycin are not advocated for patients. They have too many side effects. There's a lot of safety concerns for infants, so we do not recommend it. Your H2 receptor antagonists are used if you suspect to have erosive esophagitis, and the same with your proton pump inhibitors. If there's proven esophagitis, then you will use these. What's important is that if you do stop using it, you need to taper it so that you don't get rebound hypersecretion of your gastric acid. The problem with your PPIs is that they aren't really child-friendly formulations. Most of these might decrease the effects of the acid, but they won't necessarily decrease the frequency of reflux. They will not take it away. It's basically just symptomatic support for these patients. We've already spoken on how to manage patients with reflux, but here is a nice algorithm that just takes you through all the steps again, and this algorithm is in your notes. All right, so the next part will be on acute infective diarrhea. Diarrhea is very common, and unfortunately it is the third most common cause for death in children under 5 in South Africa. Asia and Africa have more than half of the diarrhea cases in the world, and Africa has most of the diarrhea-associated deaths. We tend to have our seasonal peaks in summer. However, if it's caused by rotavirus, these tend to occur in your cooler months. When we look at the definition of diarrhea, diarrhea is classified as 3 or more loose or watery stools in 24 hours. So you need to actually ask the mother to describe to you what does the stool look like. You will get parents that will report the patient has diarrhea because the frequency of their stools has increased. So instead of passing 2 stools a day, they're perhaps passing maybe 5 stools a day, but they're all still soft formed stools. The definition clearly says it needs to be loose or watery stools. If there's blood in the stool, we refer to it as dysentery or acute bloody diarrhea. And if it lasts for longer than 14 days, we talk about persistent diarrhea. You don't need to remember all of the physiology, but there's a reason why I'm showing you this slide. So remember, water reabsorption occurs throughout your entire colon, but more happens in your small bowel than in your colon itself. And there are various processes. But process number 3, your sodium glucose cotransporter, will stay intact in secretory diarrhea, and that will be the cause for most of your diarrhea in your patients. And that is why your sugar salt solution or your sorrel works, because this cotransporter remains intact. If we look at the pathophysiology, remember you get different types of diarrhea, and we will discuss these. With your secretory diarrhea, you get active secretion of electrolytes and water into your lumen. Your enterocyte remains intact, And this is caused by certain bacterial toxins and some of your viruses as well. In your invasive inflammatory type, you get destruction of the villi and destruction of the cells, and this leads to loss of your electrolytes, water, and mucus into the gut. And this is caused by your Salmonella, your Shigella. Generally, these types are the ones that will cause your dysentery, your bloody types of diarrheas. And be careful with these patients, because sometimes the sugar salt solution won't work as effectively because the sodium glucose co-transporter does not remain intact in these types of diarrhea. In your osmotic types, it's not really a cause of infectious diarrhea, but I just mentioned it here to complete all the pathophysiology. And with this, there's an osmotic gradient. So there's an osmotically active substance in your gut that draws water into the lumen of the gut. We're going to talk a bit now about the infectious causes of diarrhea. When we look at the pathogens, there are viral, bacterial, and other causes. Common viral one is rotavirus. However, with the routine vaccination, we are actually seeing a decline in the number of cases caused by rotavirus. Your bacterial causes will be things like your E. coli and your Shigellas. Can also be associated with systemic infections, especially in your children under 3 months of age. In those patients, diarrhea is infection until proven otherwise. And don't forget about your surgical emergencies. Let's start looking at the specific organisms. Rotavirus, as I've mentioned, tends to peak in your cooler months. It is spread by a fecal-oral route and was one of the most important causes of diarrhea, but as I've said, we're seeing a decline in the number of cases. Most of your patients that get rotavirus are under 2. However, the majority will be under 12 months of age. Its duration is about 2 to 8 days and can be associated with other symptoms such as fever, vomiting, convulsions. However, most of your patients will be asymptomatic. E. coli. E. coli is a normal human commensal, and most of the time it's harmless organisms. However, there are a few pathogenic strains. Here is a list of those strains. So if you get overgrowth of one of these, then it will cause disease. Shigella is the most common cause of dysentery in South Africa. Again, you can be an asymptomatic carrier, and the human is the only known reservoir. It's a cause, as I've said, of dysentery, so usually you will have mucoid and blood in your stools, and these can cause quite a lot of abdominal pains, a lot of cramps, as well as fever, meningism, and convulsions. These tend to complicate with hemolytic uremic syndrome and toxic megacolon. Because you have mucoid and blood in the stool, make sure that it's not an intussusception. So send away your stool MCNS, and if the history fits with intussusception, do the appropriate investigations. On your stool MCNS, you should be seeing leukocytes, and you might even culture the organism. And in these patients, this is the one indication in which you will use antibiotics for a patient with acute diarrhea. Your choice of antibiotics will be based on the sensitivity pattern in your area. If the child is small, younger than 2 months, please admit them and monitor very closely for complications. Campylobacter is a common cause of your traveler's diarrhea, and it's usually transmitted by contaminated food. It's usually self-limiting, but these are the ones that complicate with Guillain-Barré syndrome or a reactive arthritis. Salmonella, again, a lot of people can be an asymptomatic carrier, and usually it causes a very mild type of gastro, but if you have a very young patient, younger than a year, or you're immune suppressed, you can get a more invasive disease. Let's look at the history. Age of the child is important. I've already mentioned that you need to take a good history with regards to the stool, the consistency, the frequency, and then it's important to know if there's blood in the stool. What was the patient able to take in orally for the day? This will affect how you manage your patient, your choice of fluids, your route of fluids. If they're vomiting, what were they vomiting and when did they vomit? Urine is a bit of a tricky one, especially in a child who's still wearing nappies, because your stools are loose. So it's very difficult then to see whether there's still urine passed in the stools. If you do have a recent weight and the patient has lost weight, it is a sign of dehydration. Examination. So we always examine your patients fully and completely, but specifically for diarrhea, we look at dehydration, we look at shock. So remember, dehydration and shock are two different clinical entities, which we will discuss. You need to see if the child is malnourished, look for immune suppression, other signs of infection, and surgical emergencies. So let's start with dehydration. So we grade dehydration into three categories: severe, some or moderate, or no dehydration. And as you'll see, you will also evaluate your patient for shock. When we look at the difference between your some or moderate dehydration and severe dehydration, you will see the differences in the two tables. There are other clinical signs which we take into account, which I will discuss on the next few slides. So with some or moderate dehydration, these patients are irritable or restless, where severe dehydration, these patients have become lethargic or are unconscious. Sunken eyes is the same for both. In your patients with some dehydration, they still want to drink. They're eager to drink, they're quite thirsty. In your severe case, they don't want to drink at all, or they drink very poorly. And the last thing that we look at is the skin pinch. If it takes longer than 2 seconds to go back, we talk about it goes back very slowly, which is a sign of severe dehydration. And if it's less than 2 seconds, but not as quick as it should be, then we talk about some or moderate dehydration. It's important to note that your skin pinch is not a reliable sign in children with malnutrition, as they've lost some of their subcutaneous fat. So the skin pinch can be delayed even though they are not dehydrated. So in this picture, you can see how they do the skin pinch. If you look at this one, they're using the tips of their fingers, and this can hurt your patient. So rather use a bit more of the rest of your finger to do the skin pinch. I'll show you in a video so that you don't hurt your patients. Here you will see a picture of sunken eyes. Other clinical signs that can indicate dehydration are things like the fontanelle. So have a look, see if the fontanelle is sunken. Look at the mucous membranes. Are they nice and moist, or are they dry? If the child is crying, is the child crying tears? So use these things to help you look for clinical signs. All right, so let's look at shock. You would have noticed that I have not mentioned pulse rate, pulse volume, capillary refill time when talking about dehydration, as those are not signs of dehydration. Those are signs of shock. When you are shocked, you have circulatory insufficiency, and your body will need to try and compensate for this. And it will do so by increasing your pulse rate. So these patients will have a tachycardia. You will also shunt blood away from your non-vital organs towards your vital organs. So especially from your peripheries, you will shunt blood. So this will cause cold extremities, especially these patients will be warm centrally with cold peripheries. Your capillary refill time will be delayed. Capillary refill time of 3 seconds and more is delayed. Make sure that you do it properly. Make sure that you press the tip of the finger until it turns white and count in full seconds until the color returns to that finger. Your pulses will be low volume. You have to practice feeling pulses. Very, very important. You will not know what a low volume pulse feels like if you don't know what a normal volume pulse feels like. So please, please, please practice in children. If you are lethargic, it can be a sign of shock. Blood pressure. If you are hypotensive, it is already a late sign of shock. If your compensatory mechanisms have worked, you will maintain your blood pressure. However, if you do not treat the cause of the shock and your shock becomes prolonged, eventually even those compensatory mechanisms won't work any longer and you will become hypotensive. So please don't fall in the trap to say, my patient's tachycardic, I have a delayed capillary refill, pulses aren't as strong as they should be, but my blood pressure is normal. Right? Normal blood pressure, although reassuring, does not exclude shock. So please remember that. And if it's severe enough, your patients might even actually be in a coma. All right, I've already mentioned some of the differences in signs of dehydration in patients with malnutrition. In your patients with hyponatremia, your clinical signs might also differ. So I need to take you back to a bit of physiology. In your patients with hyponatremia, as your serum sodium increases, you will also get an increase of your serum osmolality. This will draw fluid from your cells into the serum. So clinically, you might not see the dehydration, as the dehydration is intracellular. So if you have a patient with hyponatremia and you hand over to your colleagues for hydration checks, please make sure that you inform them that this patient is hyponatremic. Otherwise, they might assess the patient, say hydration is normal, and stop your rehydration. We will talk about how to rehydrate patients with hyponatremia a little bit later, so just remember that their clinical signs may differ. If your patient has dysentery, they can complicate with hemolytic uremic syndrome, so have a look for this in your patients. If there are features of hemolysis, low platelets, and abnormal kidney function, then think about this as a complication. Which patients do we hospitalize? If there are any signs of dehydration, if the parent has tried home management and they are not successful, if the child does not want to drink or vomits everything, your children under 3 months as they need a full septic workup, malnourished patients or patients with high-grade fever, bloody stools, it depends on the rest of the patient's clinical condition. Your smaller children we tend to admit. Your older children, if they don't have any other signs that will require hospitalization, you can manage as an outpatient. And if you have any complications, please admit. What complications can the patients have? They can go into shock, they can dehydrate. Electrolyte abnormalities, the common ones we see are a high sodium or a low potassium. They can have acid-base abnormalities, acute kidney injury, hypoglycemia, especially if they've been vomiting and not being able to keep anything in. So please check the glucose when you see these patients. Hemolytic uremic syndrome and neurological complications. When we look at the management, your fluids and feeds will be the most important part of this patient's management. And then we will also talk about investigations, how to manage the complications, and if medication is indicated, and prevention. When we talk about the fluids, I like to teach my 4 fluid groups, as I feel that if you cover or at least think of these 4 groups, you will cover all the fluid needs for your patients. Remember to individualize for your patients. So if they have other underlying conditions, this might affect how we manage these patients. So that's why you will see the registrars managing patients differently in the wards and not precisely how I'm going to teach you on these slides. Let's start with resuscitation. A patient who is in shock, it's a medical emergency. These patients do not sit and wait to be seen. You need to attend to them immediately. Put on nasal prong oxygen. Even if their SATs are normal, we want to optimize the oxygen carrying capacity. Make sure they are able to open and maintain their airway. We want to restore circulation, so get up intravenous or intraosseous access. 3 tries at a peripheral line. If you don't succeed, please insert an intraosseous line. It is a life-saving procedure. You will then need to give your patient fluid boluses. We use an isotonic solution such as Ringer's or saline. Do not use a glucose-containing solution for boluses. You will give up to 3 boluses of 20 ml per kilogram. So you will give your first bolus of 20 ml per kilo, and by bolus, please don't ask the sisters to come and get an IVAC and work out a rate and run it in over 30 minutes. Outside of the neonatal period, that is not considered a bolus. You need to pull up your fluids, you need to syringe it in. But be careful not to blow the vein when you are syringing it in. After your first bolus, you need to reevaluate your patient. Assess the patient for shock. And you need to decide, is this patient out of shock? Yes or no? Remember, a patient who is slightly better but still has features of shock, is still in shock, you need to manage further. Before you give the fluid bolus, a second one, make sure that it is safe to do so. Listen to the base of the lungs, make sure there's no new basal creps. Feel the liver again. You should feel the liver beforehand so that you see if it's palpable, and if it is already palpable beforehand, then you need to measure it so that you can see has it enlarged after your fluid bolus. If the liver hasn't enlarged and there's no new basal creps, that means it is safe to give your next fluid bolus. You repeat your 20 ml per kilo bolus. You do the same again. If your patient is out of shock, stop with your boluses and you continue with the next fluid category. If they are still in shock, you may give a third fluid bolus. After this, if they are still shocked, then you need to discuss this patient with someone more senior, as you will have to consider pressors or inotropes to get this patient out of shock. Keep in mind, patients with malnutrition can get fluid overloaded very, very quickly. In these cases, we do not use 20 ml per kilo, we use 10 ml per kilo, and we stop after 4 boluses, so a total of 40 ml per kilo. If a patient comes in and they are shocked, sometimes there isn't always time to weigh the patient properly and to get the length and get your charts and plot them. You will need a weight so that you can at least calculate your fluids. But in terms of assessing for malnutrition, a nice, quick, easy way is to use the mid-upper arm circumference in children between 6 months and 5 years. Remember, a normal one is above 12.5. Between 11.5 and 12.5 is moderate acute malnutrition, and below 11.5 is severe acute malnutrition. As you gain more experience, you will also be able to see which patients are malnourished, or you suspect they are malnourished when they present. But do the mid-upper arm circumference. It's a quick way to help you determine what rate of fluid are you going to go. 10 ml per kilo if they're malnourished. If they're not malnourished, 20 ml per kilo. Other exceptions would also be patients in cardiac failure or known fluid overload. These ones we will also go with 10 ml per kilo. The next group of fluids is your rehydration. We will be talking just about rehydration. You will see that I do mention feeds on some of the slides. So it's just to say don't forget about maintenance. All right, so you have to do rehydration as well as maintenance as well. But let's first talk about rehydration. So how do we rehydrate the patients? It will depend on the degree of dehydration. In general, we prefer oral than intravenous. However, there are cases where you need to go IV for your rehydration. So when you decide, you need to ask yourself a few questions. What route? Are you going to go intravenous or are you going to go oral? Once you've decided that, then you need to decide what solution, what fluid are you going to use, how much, and how fast. Which patients will we consider IV rehydration? So a patient who is still shocked, a patient who's got persistent vomiting, a patient who's failed oral rehydration and you know for sure that they were given the correct volume of fluids and they did take everything in. Unfortunately, some patients just have such a rapid transit time that there is no time for absorption of the sorrel and they will then fail the oral rehydration. And in those patients, we will probably need to rehydrate IV. Another group of patients, especially if they have mucoid bloody stools, remember we said that the enterocyte gets destroyed, so that your sodium glucose transporter gets destroyed as well. So these patients generally might also have a failed oral rehydration, but you will still try it first, and if it fails, switch to IV. If you have a suppressed level of consciousness, it's not safe to go orally, so you'll have to consider IV. And if you have an ileus, which kind of goes hand in hand with your severe hypokalemia, then please don't rehydrate orally. There are other indications as well, but those you will be exposed to as you see patients, but these would be the more common and most important ones. If you're going to rehydrate orally, what solution do you use? So you will see in your notes, there is a table that compares the constituents of the various solutions, and you will see that some of them are not applicable. I know we have our old wives' tales: drink some flat Coke, have some apple juice, drink some tea, especially rooibos tea. They will provide water for your patient, but not much else. And if you don't have your salt and your glucose, so that you won't really absorb it, because you need that sodium glucose co-transporter to absorb the fluid. So that is why we use the sugar salt solution. So you can either make it at home, advise your parents to make it at home for the kids, or you can buy commercially prepared products, which you then just mix with water that's been boiled and cooled down. When we look at rehydration of your patients with severe dehydration, it's actually split into two groups. So you will see the algorithm that I use is what's used in the EDL. So if you want to refer to it later when you're doing interpretive, etc., please look at the EDL. They've got an app now, and all of this is available there. So if we look at patients with severe dehydration, we look at two categories. So those who have come in who were shocked, you now get them out of shock, or they have severe dehydration, you've tried the oral route and it's failed. You will follow this route. So you will give them half dextrose, which we also refer to as half DD, intravenously at 10 ml per kilogram per hour for 4 to 6 hours, plus your oral rehydration solution, your Sorrel, at 20 ml per kilo per hour via your nasogastric tube as a continuous infusion for 4 to 6 hours. After 4 hours, you need to reevaluate your patient and assess their degree of dehydration. If the hydration has normalized, you can stop your rehydration. If it is better, but the child is still dehydrated, then you need to make a decision as to exactly how are you going to continue. You can either continue with the exact rate, or you can play around, perhaps stop the IV, continue with the oral, or decrease the rates. Unfortunately, there isn't an exact recipe that I can teach you for that. That will come with exposure to your patients. And then, as I've mentioned, continue feeding your patient. Very important, re-evaluate your patient every 4 hours with severe dehydration and make a decision with regards to the fluids that you are using and see whether you need to change. Your patients with severe dehydration who were not shocked, they haven't had any fluids yet, we will manage the same as your patients with some or moderate dehydration. These children will be admitted and they will get continuous Sorrel at 20 ml per kilo per hour for 4 to 6 hours. If they only have some dehydration, instead of giving continuous Sorrel, you can perhaps work out, all right, my patient needs 100 ml over the next hour, and you can tell the mom every 15 minutes, please give 25 ml of Sorrel to the patient. This obviously has a few issues with it. Number one, you need a mom who's going to sit there and who's going to give it to your patient. There isn't a mom there and you are short-staffed. This is not a good suggestion. The patient needs to actually drink it. So if the patient does not want to drink, this is also not a good option either. Then rather insert the nasogastric tube, program your machine so that you're giving 100 ml per hour. I also don't recommend it in the middle of the night. Even the most dedicated mum might fall asleep. And you don't want your patient to fall behind with their fluids. You will then need to reevaluate your patient every 4 to 6 hours. If their hydration is normalized, you stop. If it's better but not normal, then continue with their fluids. If there's absolutely no response, no improvement whatsoever, before you make changes, just run through a checklist for yourself. Did the patient get the fluids? Was it correctly given? Did you calculate the correct volume? If you have and your patient is still not responding, then you will manage them as we did on the previous slide with giving IV and oral. If they are not dehydrated, you will assess them. If there are no criteria for admission, you will counsel the parents and discharge this patient home. However, very important to tell the mum to continue giving oral rehydration after each loose stool and to continue feeding. So there are a few exceptions to the rehydration as I've explained in the previous slides. The one is hyponatremic dehydration. So if you think back or to the previous slides where I spoke a bit about the physiology, where I explained that your dehydration is intracellular because you get shifting of fluid from inside the cell to outside the cell. So our brain cells cannot function if they are intracellularly dehydrated. They basically look like little raisins. So our bodies are quite clever. So what happens is those cells will make its own osmoles, which we call idiogenic osmoles, so that your osmolality remains the same as your serum osmolality, so you don't get fluid shifts. If you suddenly drop your serum sodium too much, those osmoles will not be able to clear as quickly as the drop in the sodium. So you will then temporarily have an increased osmolality in those cells, and you can get fluid shifting back into those cells, and that's when you get your neurological symptoms. You get edema of those cells, and this can be very dangerous for your patients. For this reason, you need to drop your sodium very, very slowly so that you don't get these fluid shifts. You drop it not more than 0.5 to 1 millimole per hour. So these patients, we will rehydrate much slower. There are various ways to rehydrate them, and for our registrars, I think this is one of the areas which is a bit frustrating for them because there are different ways to do it. For patients with diarrhea, we will then give them sorrel at 10 ml per kilo per hour, and we give it for 48 to 72 hours until the sodium has normalized. For patients with very high sodiums, there are other ways to do it. If you look in the EDL, they also talk about going an IV route. You might hear registrars talking about a fluid water deficit, so that is a calculation that they use to determine the fluids that they use. So I think once you're in the wards, once you get exposed to patients with diarrhea, look out for these patients, and then we will explain in detail how we actually manage these patients. But for patients with diarrhea, the sorrel at 10 ml per kilo per hour generally works quite well, and you will have to measure your sodium every 6 hours so that you can see how fast is it falling. If it's falling too fast, you need to cut back on your fluids. If it's not coming down at all, there will also be a few problem checks that you can go through. Patients with malnutrition. These patients we want to rehydrate much slower. We prefer oral. However, if there's an absolute contraindication to oral, please, you have to go IV, but you need to watch these patients very, very carefully. Whether you're going oral or IV, you need to cut back on the rate of your fluid. So instead of doing your 20 ml per kilo per hour of sorrel, you can consider going between 10 to 15. If your patient comes in with that very first category I mentioned, where you go with the half DD and the sorrel, be very, very cautious. It's a lot of fluids. So if you have a patient with malnutrition, you might need to rethink those volumes. If you have a patient who is well nourished, those volumes actually work really, really well. These patients you'll also need to review more regularly, sometimes after 2 to 3 hours, just to make sure that they don't get any fluid overload. Then the last category, you need to keep up with your ongoing losses. We usually give that orally, as sorrel as 10 ml per kilo after every loose stool. All right, maintenance. Maintenance doesn't necessarily have to be a fluid. So it will depend on your age of your patient. If you have a 4-month-old, maintenance is either going to be breast milk or formula. If you have a 4-year-old, maintenance will be a child diet. So you need to make sure that this child is still getting something for maintenance. And what you prescribe will depend on the age of the child. Keep in mind, if a child has to be kept NPO, they will need IV maintenance. So you need to always make sure there's something prescribed. If they can eat, then write up their food. If they're vomiting everything or not wanting to eat at all, then you will have to write something up to give them as IV. Right? So think maintenance, think how old is my child, what is normal maintenance for this child, and if the child cannot tolerate that, then you need to prescribe something IV for maintenance. And for maintenance, you need to use a solution that contains 5% dextrose. So for diarrhea patients, we use the half DD as it's got your dextrose in, it's got your sodium chloride and a bit of potassium. In terms of your volume, if you have to go IV, for example, you can use, you can see on the first bit of the slide, a daily rate, or you can calculate it per hour. But don't forget to individualize for your patients. Patients with malnutrition, we calculate oral feeds differently, and if you are going to go IV, you need to consider cutting back on your volume. Okay, so which investigations are we going to do? If the patient is sick enough to warrant admission, then we will have to do further investigations. I already mentioned glucose, kidney function, so that you can look at your electrolytes, your urea and your creatinine, blood gas, so that you can see your acid-base status. Stool MCNS is not indicated for every patient. If there's blood in the stool, we'll have to send it off. If it's chronic or persistent diarrhea, please send away stool MCNS. And if you're thinking there's an epidemic, if it's the fourth little toddler from a certain preschool, then those are the ones we send off. Urine dipstick, with or without an MCNS, will depend on your patient. Your younger patients, your immune compromised, your malnourished patients, please send one away. Do a dipstick, and if it's suggestive, send for a urine MCNS. If you're worried that there's other infections, please do a full blood count, blood culture, and CRP. In your smaller children, we need these. However, if it's a bigger child and there's nothing else to suggest other systemic infections, then these won't necessarily be indicated. I've already given you a list of complications. So for this list, unfortunately, we still see patients demising from acute diarrhea, so that has been added to this list. Management of complications. The management of a metabolic acidosis, rehydrate your patient. We very seldom use Sodabic in these patients. If you rehydrate, the acidosis will get better. If they have a low potassium, you need to replace the potassium. I would suggest if you have a potassium that's less than 2.5 that you consider replacing IV. More than 2.5 you can replace orally. We've already spoken about a high sodium. Every now and then you will get a patient with a low sodium. They are managed the same as you do with other patients. If they're between 120 and 130, you will replace the sodium if they are symptomatic. If it's less than 120, you will replace regardless of symptoms. If you are not sure, phone a friend to help, phone a senior person to assist you with management of these complications. Medication. Antibiotics are not routine for patients with acute diarrhea. If you have other infections, a UTI, meningitis, pneumonia, you will start antibiotics for that. If you have dysentery, that is the one indication to use antibiotics for diarrhea. You can use ciprofloxacin as an oral choice, or you can use a cephalosporin for IV choice. If you've sent away a stool MCNS and you get back a positive culture with a specific organism, those are the ones you will treat, and your choice of antibiotics will be dependent on the culture and sensitivities that you get. Patients with malnutrition will get antibiotics as per the SAM protocol, and if you're immune suppressed or less than 3 months old, the diarrhea can be a sign of a systemic infection. You will start these patients on antibiotics until you get your results back for your septic workup. If your septic workup is negative, you can stop the antibiotics. If you are going to give antibiotics, it's better to go IV on the initial phases, so that because with the oral route, the absorption is quite poor. Our first line choices are generally ampicillin and aminoglycoside, so gentamicin, but keep in mind that gentamicin is nephrotoxic. So if you have a patient with severe dehydration where you suspect acute kidney injury, you might want to avoid gentamicin. Vitamin A improves the mucosal integrity, but before you give it to your patient, please have a look in their Road to Health book. If they haven't had it, you can give them. Do not overdose them on vitamin A. Please give all your patients with diarrhea zinc. It does reduce the volume of diarrhea and the number of days as well, and we give them zinc for a total of 14 days. Your anti-motility drugs, we do not use them. Loperamide, again, one of the things contraindicated in children. Okay, so your anti-motility drugs will actually mask some of your symptoms. They can actually mask dehydration, and they can actually cause increased absorption of your toxins. They are not cost effective, so please don't use them. Probiotics, the studies that have been done are very promising. What we still need to figure out though specifically is which strains and at which doses will they actually be the most effective. Studies do show that it can reduce the diarrhea by 1.5 to 2 days as well, but we still need further research on this. How do we prevent diarrhea? Access to good, clean, safe water, breastfeeding, having clean toilets, getting the necessary immunizations, and hand washing. Please make sure that you wash your hands properly so that you decrease your risk of getting acute diarrhea. Immunizations that we have, rotavirus is part of the immunization schedule. It must be given before 6 months, and there are 2 doses that are given. If you are traveling to an area where there's cholera, there are vaccines for cholera as well. Right, and the last bit to remember that certain organisms, if you grow them or culture them, these are notifiable. So Salmonella typhi, cholera, listeria, or any epidemic. Thank you for listening to me. Please make sure that you use these slides in conjunction with your student notes as well as the relevant chapters in Kuvadia.